So based on the real-world outcome, even if FOLFIRINOX is not for everybody due to the adverse events such as diarrhea, neuropathies, adverse events, and fatigue, in the real-world outcome, in all the state of the pancreatic cancer, advanced metastatic, unresectable locally advanced, FOLFIRINOX seems to favor than nab-paclitaxel. In addition, the patient treated with the FOLFIRINOX had less frequent in the emergency department visits and all-cause hospitalizations rate. So does it mean adverse events is manageable in the FOLFIRINOX? Regarding to the ESMO guidelines 2018 or 2019, so the FOLFIRINOX and gemcitabine plus nab-paclitaxel is the first option in the first line in the metastatic pancreatic cancer. So now, the FOLFIRINOX and gemcitabine nab-paclitaxel regimens has been improving the median overall survival. The question is that it is possible to implement maintenance therapy. My response is yes. In fact, maintenance therapy has been used already in the several cancers like ovarian cancer, lung cancer, and colorectal cancer, and non-Hodgkin's lymphoma in the hematology. So first maintenance therapy is chemotherapy. In France, FFCT prodige 35 is widely used in the clinical practice, in fact, in the patients with metastatic pancreatic cancer. 8 cycles for FOLFIRINOX follow up by LV5 fuse until to progression disease. You can see this design of this trial. And then the primary objective is 6 months PFS rate is 40%. So median arms on B was considered as effective. In terms of the progression-free survival, maintenance arms with efficacies as well. The rate of reintroductions of the FOLFIRINOX is approximately 30%. It means that this regimen showed good tolerability. In terms of median overall survival, it is favored also for maintenance therapy, and this efficacy is maintained in the long term. You can see the almost 28% patients have the benefits with 18 months overall survival. So targeted therapy is also used in the maintenance strategy. So the first trials targeted therapy in maintenance is olaparib. As you see, BRCA's 1 and 2 mutations is observed also in ovarian cancer, breast cancer, and pancreatic cancer. The rate of this mutation is limited from 4 to 7% of the pancreatic cancer. The first targeted therapy trial is POLO, phase 3 registrations trial. So 154 patients with the metastatic pancreatic cancer, BRCA's 1-2 mutation, and previously treated with the first-line platinum-based therapies without progression disease. And this patient is randomized in the olaparib arms as maintenance therapy and placebo arms. The result of the primary endpoints, median PFS, is statistically significant also. 7.4 versus 3.8 months, with other ratios 0.53. So that is very, very encouraging results. ASCO GI's 2021 meeting, even if medians over the survival of this trial is not the difference between the two arms, but however, like banopitomox, as I mentioned previously, 5 years in maintenance, more patients have the benefit in terms of the long survival. And finally, thanks to identifications of the genetic mapping in pancreatic cancer, we enter to the important precision medicine. Based on the KEYNOTE trial, we identify only 1% of the pancreatic cancer associated with MSI high. 2 out of those 4 patients with MSI high had objective response. And based on the KEYNOTE 028 and the KEYNOTE 138, finally, pembrolizumab is recommended as the second line for the pancreatic cancer patients with MSI high in ASCO and NCCN guidelines. So question is how to potentialize the immunotherapy. 40% MSI high patients resistant the immunotherapy, you can see. And beyond the MSI high, the investigator could propose the 2 strategies will consider it promising. First one is quality of the neoantigens and also TLS. So the first one, neoantigens, not only quantity of the antigens is important to play the predictive role of the immunotherapy, but also the quality of the antigens is important to stimulate the lymphocyte T cells. So if antigens is good quality, leading the higher TCR affinity for the antigens. By consequence, this connection stimulates the T cells expansion and the high number of the TILs. So you can see the quality model was better able to predict the overall survival comparing the quantity model. So this result is published in the Nature and Nature Reviews. Somebody said the pancreatic cancer is not immunogenic, but however, TLS quantity is correlated to the OS and the PFS. In fact, the tertiary lymphoid structure TLS find it in inflammation, infected, and the tumors tissue. So, in fact, how potentialize the immunotherapy? That is also the good question. You can see that this table show the standard of the course immunotherapies in the lung cancer and the melanoma. So I propose 3 strategies to consider in the future. The first one is to identify the 30% early progressor patients profiling. And the second one, improve the efficacy in 60% patient. And finally, how is best way to maintain the 20 to 40% long survival patient?